Welcome to the Oral Apothecary Podcast, authentic chat about medicines, pharmacy and healthcare in the UK.
Pharmacists Jamie, Gimmo and STC take on topical and controversial stories, but keep it edgy yet light-hearted.
Guests share their career-defining drug, song and book, and also share their joyful patient stories. Welcome to the Oral Apothecary Podcast. My name is Jamie Hayes. For this episode, we're looking at poisoning, as we're joined by Dr Laurence Gray. Laurence is a consultant clinical pharmacologist and is director of the National Poisons Information Service in Cardiff. We'll welcome Laurence in a moment as he shares a drug for our formulary, his career anthem, and recommends a book for the Oral Apothecary Library. Our micro discussion this week looks at poisoning in adolescents in the UK, a review of inquiries to the National Poisons Information Service, a paper from Archives of Disease in Childhood. But first, let me welcome my two fellow apothecaries. STC is in Bournemouth and Gimmo is in Cardiff. Welcome both.
Evening. How's it going?
What have you been up to?
Not much for me today. I think I've been reading. I do try and when a book of a guest catches my fancy, I do try and read it. So I was reading Strong Poison this week, which is by Dorothy L. Sayers. Do you remember who recommended that?
Oh, Matthew. When we talked about risks being guidelines causing risk,
Dr. Matthew Jones
from Bath, wasn't it? And I just thought it was relevant to today's episode, really, because we're gonna chat about poisons a bit. But a spoiler alert for anyone who's ever thinking of reading it: tune out now. But it's at its heart is arsenic poisoning. So maybe Laurence later can give us a view, but the criminal sort of evades capture by making themselves immune to arsenic by microdosing, so that when they take the poison, he's not affected. And so there's a bit of a pharmacology element to it. I'm not sure if it would work, but it was good. Although not my favourite, to be honest. I prefer Agatha Christie. I didn't really like Sir Peter Wimsey.
I also tried to start the book that Jess from the AI episode gave us. It was very hard going. I need to go back to it. You know, when you start a book and you think I need to be ready for this.
The title took about an hour, didn't it?
But we have had lots of really good feedback, haven't we, about the Jess Morley episode?
She was brilliant. She was absolutely superb.
Yeah, lots of listens, really good. So thank you, Jess. And my points on this are that I got quite a few comments saying, yeah, you know when you said, I'm going to sound like a Luddite, and then you said you'd never used AI, that's exactly how you sounded. So that's a fair comment. And also we probably fell into the trap of AI as in the broadest sense, whereas I think we were trying to talk about its use in a clinical sense with patients in front of us. And I think that we will come back to it. And James McCormack, the lovely James McCormack, Professor of Pharmacy, previously guest on this show, also contacted me and said, Steve, would you like a tutorial on how to use ChatGPT to help you in clinic and also to doing teaching? So well done, James. I this week had my first tutorial on ChatGPT. Not my first, actually, because Jamie showed me after many gin and tonics when we were in Spain recently at the weekend. So yeah, I might become a convert soon, but I do think we'll definitely come back to it. And Brian, thank you. Yes, we didn't consider the patient angle either. But because AI was very much in my mind, let me just tell you this, that I got asked a few weeks ago to go to a sixth form this week, somebody I cycle with, and I took my friends with me. So I took Dr Laurence Brad and Dave, the paramedic, who's also been on here, plus a nurse, Tufty, and we had a fairly tough gig, which was the sixth formers, and to talk to them about the careers in the NHS. So it was actually really good. We really enjoyed it. I tried to keep it edgy and interact with the students as much as possible. So I got permission to use Slido, so they all had their phones. And one of the questions I asked them was, are you worried that AI might mean you struggle to get into any job that you want, not necessarily healthcare? Guess there's 50-odd people in there. Are you worried that AI might mean that you struggle to get any job that you want? What percentage do you think said yes?
Pretty high, 70, 80%.
Spot on, 68%. So we then went on to describe why, with some exceptions, we're going to need lots of humans working in NHS and healthcare. So we boshed it to them, basically.
Did they ask you how much you get paid?
We did talk about payment, and we did talk about the top trumps of working in healthcare, and particularly the NHS, around pensions and sickness and equality, diversity and inclusion and all good stuff like that, because the NHS is brilliant for that sort of stuff. And 1.7 million people work there. Don't mess around with our pensions.
Very good. One thing from me, look, thanks to Natalie Fasham, Deputy Chief Pharmacist from Northamptonshire, for sending me some BNFs for the collection. Remember when we did the BNF blog and I mentioned the BNF collection? So she sent me BNFs from 1963, 1968, 71 and 76. So just predating the modern BNF, but I will add, thanks Natalie, I will add them to the collection, and one day soon I'm hoping the collection will find a good home where everybody can enjoy it. I can see our clinical pharmacologist on the line. He's bursting with excitement at that thought.
Well, I'll put a link in the show notes to the blog again, because just a reminder, because it was last series I think we mentioned it, wasn't it? But it's a great blog on the BNF and how the width and weight has changed over the years. The girth. I didn't like to use that word; it just feels wrong.
Yeah,
but I'll put the link in the show notes.
Let's move on. A great pleasure to welcome Dr Laurence Gray to the Oral Apothecary. I mentioned Laurence is Director of the National Poisons Information Service in Cardiff. The service advises healthcare professionals on the management of poisoned patients across the UK. Laurence is a colleague of mine. He also has an interest in drug allergy and leads the local adverse drug reaction service. Welcome to the pod, Laurence.
Hello. Can you hear me?
We can.
Oh,
we can.
Fantastic.
So, Laurence, we've bumped into you in a pub. What you drinking?
Yeah, I think I'm probably going to go. It depends where I'm in the night. I think early doors, craft beer, and later on, then I'll probably move to something a little bit stronger.
Tenant Super.
I'd probably move towards the spirits rather than the old purple tin. To be honest with you.
Yes. Okay. And
quite toxic otherwise, isn't it?
Yeah.
And professionally, Laurence, what's on the top of your agenda at the moment?
Yeah, I think there's a few things which I suppose are causing a little bit of alarm. I think something that we're trying to highlight at the moment is the dangers of propranolol, and so as you're well aware, a beta blocker that's been with us for a long period of time, since the 1960s. Very effective and used quite correctly in prophylaxis of migraine and so forth, but also is used for the treatment of anxiety, and unfortunately we appear to be seeing a trend towards the use of propranolol. And I think that's something that we're keen to highlight. And I think also in tandem to that, because it tends to affect a younger age group, we're also seeing potentially younger people taking intentional overdoses, and there's been some studies, some of which we may discuss tonight about that as well.
So before we go into any detail, Laurence, from my perspective, I can see I think what your working week looks like roughly. Just give us an example of the type of thing. So consultant clinical pharmacologist. So you're on medical admissions unit. What does how do you divide the sessions and the working week up in a broad sense?
It's all a bit variable. So a large part of my week is taken up with toxicology, and we provide updates to the tox-based monographs, which you may or may not have interacted with. Essentially an internet-based clinical guidance for healthcare professionals. So for example, if you were treating a patient who had taken an overdose, bitten by an adder, swallowed bleach, you could use these guidance to help guide your initial management. And the National Poisons Information Service is made up of 4 units, Cardiff being one of them, the others being Birmingham, Newcastle and Edinburgh. And we make sure those monographs are all up to date. So that's part of our role. We also take phone inquiries. So sometimes, as you're all aware, the guidance or written guidance is enough. You need to talk to someone about it to kind of clarify the best way forward. So we do have a 24/7 phone line. Your initial call will be answered by a spy. So that's not someone involved in espionage. That is a specialist in poisons information. And they'll be able to give some advice. But if the case is particularly serious or maybe a bit more complicated or in one of those grey areas that falls between kind of guidance, then they'll contact someone such as myself or one of the 16 other consultant toxicologists in the UK to give more specialist advice. So that takes up a bit of time, and we have an out of hours on call for that service. Which is a 1 in 17 rota. So from 6 in the evening till 9 the next morning, we will be the consultant on call for the UK essentially, and we do 24-hour chunks at weekends, so Saturday, Sunday. So that takes a bit of time. I also do general medicine. So I do my general medical on call. So I've just finished that today. I do the adverse drug reaction service, and that's probably about a day of work every week as well. And essentially, anyone who has a significant reaction to a medication, we can perform skin prick testing, intradermal testing, and also drug challenges. We also investigate aspirin allergy, and we are just setting up a service to look at perioperative reactions, which are a little bit more complicated because they, of course, lots more medications being exposed concurrently as well. So there's enough to keep me busy. We also visit the emergency department and do a kind of in-reach thing. So, and on top of that, help out with the All Wheels Therapeutics and Toxicology Committee because I chair the All Wheels Prescribing Advisory Group. So yeah, it's great. So anything that drugs are involved in, I kind of feel that I'm involved in some form or another. But it's incredibly variable. So lots of clinical work, a little bit more kind of cerebral guideline type stuff as well. Yeah, so I would certainly recommend it wholeheartedly as a specialty.
Well, it's a great advert for Steve and his sixth formers. Look, there we are, the variation you've just described.
Yeah, we talked a lot about variation. So keen listeners to this podcast might remember there was only last series that we had Dr. Lauren Walker on, who's a clinical pharmacologist, who you might know actually from Liverpool.
Yeah. And
we also talked about ToxBase previously on episode 3.10 with Dr. Peter Turton, who was an anaesthetist. And guys, do you remember what Paul and Jamie, do you remember what Pete Turton is quite a funny guy. We had him on because he was big on Twitter at the time. And guys, do you remember what Pete Turton's main gripe was about ToxBase when we talked about it? Anyone remember?
No.
He said, "I'm on so many WhatsApp groups, and once a week it comes around. Who's got the password for ToxBase?" And he was saying, for something so important, why is it not readily available? I'm not expecting you to answer that. And I used to work in medical admissions for many years before I worked here. And I used to do the post-take ward round. So I would be coming in, and I've discussed it previously. I won't go into it again. People, 7 o'clock in the morning, and then finding out, because a fair chunk, maybe 5-10% of admissions on a given day might be people who've taken an intentional overdose or unintentional. So yeah, and given the amount of medicines that we use, it's not surprising that we have a lot of toxicology and therefore excessive amounts. And I think we'll come on and talk about that later, won't we? I'm particularly interested now in the propranolol because now that I work in primary care, and I've spent the last 7-9 years working in primary care, when it first came out, I think there was one of these coroner's reports last year, and then I think the Health Safety Board, HSSIB, came out with a report on the basis of that. And I have to remember when I first read it, I thought, I guess I would say I wasn't typical because I was like, yeah, I know that. And then I think the point and the paper that I've seen that you've been involved with, I think is very fair, which says we just need GPs and those in primary care to realise that there is a real risk. So most of them would say, yeah, we know we shouldn't use propranolol in anxiety for somebody with asthma, but they don't actually make the connection. And that's really what you're trying to say here, isn't it? You're not saying ban it, because actually our previous guest said how successful propranolol was for physical anxiety symptoms. And it is very successful. I've taken it myself. But your point is, you have to remember, like all medicines, there's a harm and there's a benefit. And you're not suggesting that we ban it, are we? But it's quite shocking the number of deaths that there are. And when you look at the lethal dose, it's not that high, is it? And I think we discussed it in our practices and said, look, the key message is this. If you've got somebody that you're worried about from either previously overdosed or you're very worried about, not saying you can't use it, but you really need to think carefully about the amount that you give them, and don't think that it's without risk.
Yeah, I think that's very fair. I think it is a drug that's been used a long time because it is effective. But as you say, I think it's just recognizing those maybe at risk populations. I think it's interesting with the HSIB report, the Health Safety Investigation Bureau report. I think it seemed quite good prescribing in some ways because the patient also had problems with migraine.
Yeah.
So, that was one of the reasons that this index patient that they kind of talked through the patient's experience was on it. But I think the key thing to highlight is that if there are concerns about mental health issues, just look at the quantity. And as you also said, poisoning and overdose is really a disease, if you could put it that way, of convenience. It's what you have around you that you will choose. So if you and it's on a national as well as a personal level. So if you generally, as we see an increase in prescription of a medication or the availability, it doesn't necessarily have to be prescribed, then you will see an increase in overdoses with that medication because you use what you have readily available.
You presented, didn't you, at the All Wales, the AWTTC event a couple of months ago on this, and so I was in the audience then, and I think generally people were surprised, I think, about talking about propranolol as a dangerous drug because it's one of those ones that you sort of, as Steve said, it's quite often prescribed partly because it's perceived to be not benign but fairly safe. And I would challenge you slightly, Steve, about the effectiveness, because when a lot of the papers and stuff, I know it's got some effectiveness, but actually it's not really recommended in anxiety, is it? It's used because it relieves the symptoms, but actually it doesn't solve the problem.
I think I'm agreeing with you there, and I think that's the other education bit is it's good for the people who actually have the physical symptoms of anxiety, right? Which is why people used to take it before tests or exams or
and there's something of a benzodiazepine about this, isn't there, in that it's overprescribed because of lack of other viable options, really, isn't it? And that's the problem. That's part of the problem, and that's, I think, one of the things that comes out in your paper, isn't it, Laurence, is because, sorry, we should say there's a paper related to this that we can share that we've all looked at, which explores this a bit more depth. That's one of the things, isn't it, is that really this is yet another example of GPs and primary care in general not having access to the services that it needs to address those anxious symptoms. But
you mean non-pharmacological aspects? Yeah, absolutely.
100% with you, and it kind of does not only affect our prescribing, and I think we've got a kind of need which cannot be really helped with medications, certainly medications alone, and that we can see that in the prescription patterns for a lot of different medications. So maybe propranolol, gabapentin, pregabalin, and these types of medications, and even opioid painkillers. So I think as we try and shift our prescribing of each of these different medications, we are having to try and divert to another medication because actually we're just trying to meet this need that, to some extent, that we can't meet even with any pharmacological method. And I think I would really support your point about the lack, I suppose, of CBT counseling therapies and these kind of things. And we talked a little bit about adverse drug reaction service, and I do see a lot of patients who some of the reactions they have are kind of stress responses, but it's very difficult to manage because there's no one there really to be able to give them the counseling and the support. And I think that makes it it can be quite difficult to manage these patients. And certainly for primary care colleagues, the volume of patients that you see, the time you have with the patients, and the change in the relationship between the patient and the doctor, it all makes it much more difficult in a consultation, I think, to address a lot of these slightly deeper issues.
And my point, sorry, Jamie, just to finish, was my point about it relating to benzodiazepines is the other similarity is they were only ever meant to be prescribed short term and acutely, and they end up being chronically prescribed. And I think that's probably similar with propranolol as well.
Yeah.
God, just so for the record reader, the paper that Laurence is part of, Hayley Williams, the problem of propranolol prescribing in British Journal of Pharmacology, and you do reference it in your paper, Laurence, as well, but to read alongside it, I would say, is the GP's views of prescribing beta blockers for people with anxiety disorders, and that's by Charlotte Archer and colleagues from Bristol. And that's the one that really explores the primary care clinician's perspective of why. And that's a fascinating read about what our primary care clinicians think about propranolol and why they end up prescribing it, and it's for a variety of reasons. One of which is they think it's effective, one of which they think it's relatively safe. I think that's the words, and I know they're dangerous words to use with a clinical pharmacologist on the call. But yeah, I would read that paper alongside your paper to get a full picture.
Yeah, they make an interesting point, which I agree with. Is it's a bit like a pill in the pocket. You say to people, if you think you're going to, that you've got to give a presentation, for example, at work, and you've got terrible anxiety, and you know how much it's going to tax you, then that's that kind of when required use, isn't it? And that really, certainly when I prescribe it in those kind of, I'm at pains to point that out to people. In other words, it isn't really for a regular use, which is where it doesn't have much effectiveness. So, but if you like, in closing in on this, and I'd be interested in your view on this, Laurence, that is why you can't just ban drugs, okay, because they all have a place. And that's why the person who is the prescriber has got to think, they've got to engage their brain, and they've got to prescribe by exclusion in the same way that clinicians diagnose by exclusion. That's the way I always try to describe it. So if you've thought about it, and you've thought about all the other options, and they're even worse, but you've got to do something, then it may be appropriate, but you need to give worsening advice guidance and still think about what the possible risks are. And that's all I can say, really, from a prescribing point of view.
100%. And I think it's also it's a two-way thing as well, isn't it? So I think it's about the patient being aware as well. And I think, you mean, propranolol in anxiety, I don't think is particularly pure anxiety. Maybe has a role for some physical symptoms, but I think is not the best choice. And certainly in a patient with anxiety and risk of mental health, I think it becomes a much more complicated choice to make. And I think, as you said, there may be instances where you're willing to do that, but I think it's having the checks and balances in place to ensure safety and to be aware of maybe what you're doing. As with any other medication that we prescribe.
All drugs are poisons.
They are, I wasn't going to bring up Paracelsus. Every toxicology talk you'll ever see is a picture of Paracelsus and the dose maketh the poison, etc., etc. So I guess I've now done that in a very kind of slightly
excellent. We brought you into that nicely, didn't we?
Can I just check with two clinicians on the call? Look, if I came to you and said, I don't know, I'm doing a big TEDx talk, I'm really nervous about it, how would you manage that, you two?
I would be very disinclined to give you any drugs at all, to be honest with you.
Good answer.
I would agree with you, but I've been working for 34 years, right? And it's only really in the last 5, 6, maybe 7 years that I've come round to. So, for example, a good and similar example is where people still ask us for, can I have some diazepam to fly on a plane, right? And only recently that the practice has really, clamped down and said, look, there's some good evidence that if you go and do one of these CBTs or something specifically around flight anxiety, you'll actually get a better result and there's no risk involved, which is essentially the same as this, isn't it?
Yeah, and I think that's exactly where we've got to kind of get to. And I think you can probably, I know that if it's last minute, you may have time to engage the CBT, but there's probably things you could
Yeah.
could do
I mean,
to
I've
me.
got some you could have, James.
But I'm just going to say about the diazepam and flying. We've got a kind of family friend, and she's an air stewardess, and some of the stories she tells of patients who've taken a diazepam to ease a flight. You mean they themselves have ended up being escorted off the flight for their behavior. So, there's
Yeah, two sides to every coin.
it doesn't just make you super relaxed; it can also make you incredibly disinhibited. So,
Especially with an in-flight gin.
yeah, so she's told some funny stories about these seemingly normal people who had taken a bit of diazepam or whatever to fly, and it didn't end particularly well, maybe for them. So
That's a great analogy, and we all have to be wary of our own personal biases, which again is something that I never would have talked about 10 years ago, but now I have a personal bias because I've used propranolol in an anxiety sense, so I have a personal bias.
and physically, I mean, it was banned in snooker, wasn't it, and darts?
Yeah,
It probably
we
still
talked
is.
about that. We talked about that actually on the Jess episode. Bill Werbenick, and they were all on it, weren't they? Cliff Thorburn.
Yeah, Bill Werbeniuk also had about 11 pints to the good every time he played. The Walrus, they had their names, didn't they? So there was
They
Bill
did,
Werbeniuk.
yeah.
He was the Walrus.
Yeah. To be fair, it went right over Jess's head because she was too young to be talking about 1980s snooker players. That witticism has been retired.
I can't think there's many podcasts where Bill Werbeniuk gets a mention, so I think
But
that's
it's
like
good,
a
isn't
big
it?
one.
Yeah.
Kirk Stevens.
Two episodes on the run.
The Oral Apothecary is sponsored by Jamie Hayes Executive Coaching and OneLessPill.com.
Right, okay, that's great chat. I'm sure we'll come back to some of this when we look at the micro discussion. So, Lawrence, you will know that you get the pleasure of offering 3 things to the Oral Apothecary. We do it in a strict order, of course. The first one is, some like to call it a memory-evoking drug. I still like to call it a desert island drug. But what would you like to give us as something that would evoke a powerful memory for you?
I think it's probably got to be acetylcysteine. I guess, I've coming from a toxicological line. I think, from a clinical standpoint, I think probably the first time you give adenosine is probably a very memorable experience. So essentially, you cause someone to have asystole for a couple of seconds, and it is a bit of an experience. But I think from my, I suppose, career in toxicology, I think acetylcysteine probably has been the defining drug as a treatment to paracetamol, and it's quite amazing. It was just under about 50 years ago, or maybe just slightly over 50 years, the first case report started to come about paracetamol toxicity and liver injury. And then in the late 70s, the use of acetylcysteine was suggested as an antidote, and really had a major impact on mortality and morbidity from paracetamol overdose. And paracetamol remains the most common pharmaceutical overdose in the UK by far. So about at least 50% of presentations to hospital are for paracetamol overdoses. So I'm going to go for acetylcysteine. The regimen's been through a few changes. So it used to be 20. Well, initially it was 21 hours. Sorry,
Good
20
on the regimen. I fully expected from a true clinician to go with regimen, not regime. So well done, Lawrence. You passed there.
So it was 20, I think initially 20.25 hours, and then they extended to 21, and then now we've got SNAP, so which is the Scottish and Newcastle abbreviated protocol, and that is
Snappy.
12. Yeah, I know, it's half the battle's getting the acronym. And
So when we think about drugs, the effectiveness of drugs, and we it often comes around on this podcast is what's the best drug or variations on that theme. We probably don't think of acetylcysteine, but it's probably got a case for the amount of lives it saved more than many other drugs, hasn't it? I would have thought.
Good point.
Yeah, I think so. I think certainly it's very effective. I think if it's given in a timely manner, which causes some complications because, of course, it's the paracetamol itself generally is not the poison. It's the metabolic kind of product of paracetamol is the poison, and the acetylcysteine ameliorates that. So it's only if you give it in enough time to prevent the formation of the metabolic product that you can offset toxicity. So it's got a window, and I think one of the, I suppose the search is for something that could maybe collate these metabolic products. Is there something to do with other aspects of paracetamol toxicity that could be more effective at a later time? And probably also, is there a better way, because we see kind of slightly idiosyncratic responses potentially to paracetamol overdose, is there a better way to identify those at risk using forms of biomarkers? So I think, yeah, acetylcysteine's been amazing, and has really made or improved outcomes in paracetamol overdose. But we, as toxicologists, we still love to talk about it and discuss the best way to manage it and try and improve it.
Tell me, as a CPD entry, back in the day, I can hardly say that, it's only 10 years ago, but it was always still said, I don't know if this is actually true or has been found out to be perhaps not necessarily as evidence-based as we thought it was that if you took your paracetamol overdose with a good slug of an acute amount of alcohol, that actually that gave you a protective effect. Whereas if you were a chronic alcoholic, you were more likely to see the toxicity. Does that still stand up?
I think we haven't really got the evidence for that. I think the difficulty is that of course, it's due to enzyme inhibition and enzyme induction with alcohol. And as I said, NABK, which is the toxic metabolite, is metabolized by the cytochrome 2E1 enzyme. So potentially, if you're drinking lots of alcohol, you'll induce your cytochrome of enzyme induction and produce more NABK. But of course, the other thing to say is if you drink lots of alcohol, you're more likely to have liver problems. You're more likely to be malnourished, and then you're also, if you're malnourished, you're more at risk of paracetamol toxicity. So I think it's quite hard to differentiate.
Okay.
But it's a really good point, because a lot of people are looking at the role of 2E1 in paracetamol toxicity. And one of the other antidotes that we use is fameprazole. So that inhibits alcohol dehydrogenase. So if you take a toxic alcohol such as ethylene glycol or methanol, once again, it's the metabolic products of these that are harmful rather than the ethylene glycol or methanol itself. So if you can prevent their metabolism by alcohol dehydrogenase, then you can prevent toxicity. And fameprazole has a very high affinity for alcohol dehydrogenase and therefore stops methanol and ethylene glycol metabolism. But it also inhibits 2E1. So there's been quite a few studies which have looked at fameprazole use in paracetamol.
Okay.
There's a couple of drawbacks with it.
It's very expensive.
It is is a major one. It's super expensive, and it's difficult to know when would you give it and who would you give it to, and also potentially does it have an impact on your half-life of your paracetamol? So are you going to have to prolong treatment? And so generally it's been shown that potentially there may be a beneficial effect, but of course it's never not given, if that makes sense, with acetylcysteine. So it becomes quite difficult to disentangle the benefits of fameprazole. And also cimetidine has also been looked at, and that there were some studies in the 1980s looking at that, and that's recently kind of come back into fashion again. Whether that
what goes around comes around.
Well, I'd like to thank you anyway, because my CPD portfolio is due, and that's going right in there.
There you go.
The jargon monoxide ometer is flashing a little bit too.
Jamie's nearly passing out with jargon monoxide poisoning. That's
okay. Usually I come in and say for the non-health professional,
yeah,
but
go on.
It's all good stuff. We have talked about fameprazole before on this
Have we?
podcast. Yeah, we mentioned ethylene glycol poisoning before, so it's okay. I've got my eye on the jargon monoxide.
There was a program on TV about that. I think last night. It was those poor kids in, was it Bangkok or Thailand, who
Laos.
were shots of methanol?
Yeah.
The limoncello.
Oh, no.
Yeah. That was tragic. Anyway, sorry.
Horrible.
Yeah.
Okay, right. Well, it's a pleasure to accept acetylcysteine into the oral apothecary formulary. It's a classic drug. Love it. Okay, you can loosen up a little bit now because we're now going to ask you for your career anthem, which goes into the Oral Apothecary Spotify playlist. So what would you like to give us and why?
Right. I think this is a little bit controversial because I've gone for, it's like an artist, but I've kind of gone for my favorite song of his at the moment,
Okay.
and it's got like a health aspect in the title. So it's Ambulance Blues, and it's by Neil Young.
Okay.
It's from his album On the Beach, and I've basically been a Neil Young fan for 30 odd years, since I guess late teenage years. So his songs have followed me through all aspects of my life. My appreciation of his work is often roundly mocked by sometimes friends and colleagues.
Like Jamie.
Fellow podcasters.
But I think he's an inspiring guy. I think he's I think it's important to say you don't have to always necessarily agree with the people who produce music, but I think he's someone who just does what he wants to do. I think no more so than Glastonbury. So in a digital
Played
age,
what he wanted.
he just went analog, and he's like, "This is it. 4 guys, band, big speakers, off we go." And so big Neil Young fan, and Ambulance Blues as that, I suppose, healthcare title, and it's got this wonderful kind of fiddle refrain in it, and it's actually more of him looking back through his time. He's Canadian, kind of coming through in Toronto and the times he had in Toronto and stuff like that. So it's not. I know it's not "I Will Survive" or.
No, every song has its place. It's very eclectic.
So it's a little bit too. I know. You did say not to be too eclectic, but I was like, yeah, I think it's got to be Neil. It's got to be Neil.
We like eclectic. That's what we're saying. We did previously. Dr. Neil Maskery picked "Our House" by Crosby, Stills, Nash and Young.
Yes,
that's the same Young, isn't it?
It is the same Young, and they were a curious bunch because Neil Young, they brought him in for a little bit of fire, But I think it was a difficult group, and there's a story.
It sounded like it was.
In his biography, he was staying, I think, down in Florida with Stephen Stills, and I think they were trying to record an album, and then Neil Young just left without telling anyone. And he left this note apparently in the house to Stephen Stills saying, "Eat a peach, Neil," and that was it. And off he went.
Okay.
So I think it caused a bit of consternation. But
4 grumpy old men right there.
Yeah, I think so.
Okay.
But yeah, Helpless. I don't know if you know Deja Vu. It's a great song on Helpless.
Okay. Well, I don't know Ambulance Blues, but I do like a bit of Neil Young, so it'll sound great on the Oral Apothecary Spotify playlist. Okay, and the third thing is a book for the Oral Apothecary Library. So what would you like to give us?
So I had a long think about this, and I wasn't actually necessarily minded to choose a healthcare-related book, but a book that did impact me actually was One Flew Over the Cuckoo's Nest by Ken Casey. So Ken Casey, of course, is a figure from American counterculture. So remember the Merry Pranksters, I think, and he wrote One Flew Over the Cuckoo's Nest. So, and why I chose it was for a couple of reasons. I guess many people have seen the film, which I think is an excellent film with Jack Nicholson, and the main character, McMurphy, decides or he wants to avoid incarceration in a prison. So essentially, he kind of feigns a mental illness to get incarcerated in a mental hospital, and it just illustrates a few of the struggles that he has. So he realizes very quickly that in some ways he has less freedom in the hospital than he would ever have in a prison, and it's not entirely clear what the rules are for him to actually leave. I think there's also a really interesting aspect where he is also quite rebellious and full of life, and he inspires a degree of rebellion within the other patients there, and kind of disobedience, and giving kind of self-confidence and a little bit of autonomy back to these people who have been kind of ground down and forgotten about. I kind of like that aspect to it. And then the kind of third aspect, there's a great scene. I don't know if any of you read it, where because he's like a gambler and kind of a bit of a kind of wide boy and all this, and he's well versed in fighting and gambling. He's spent the whole time taking money off the other patients at card games. He's always winning at the card games, and he's taken all their money. And of course, everybody starts to get upset with this. And there's a kind of water fountain in the middle of not maybe not in the middle, but in the ward.
Like on every NHS ward.
Yeah, and it's like bolted down, like it's super heavy. And he says to them, "I bet you I can lift this. I can lift this." And of course, all the other patients, their eyes light up because they realize it's impossible. Someone going to be able to lift that. So they all bet heavily on it to get all their money back. And he says, "No, I'm going to do it. I'm going to do it." So he sits there and he strains, and there's pulling at it so hard, like the blood is coming from his hands, and he loses. And then he gives them all their money back, but of course it's all stained with his blood. And there's this idea about, he's there trying to create hope and ambition, and then these guys, they saw the chance to get their money back. And yeah, it's a really kind of quite.
Is that bit in the film? I mean, I've seen the film, but I can't say I've read the book.
That bit I don't think is in the film, because I think the film more concentrates on his inspiration of the patients, but that bit is in the book. And I think it's that water cooler that or water dispenser that's thrown to the window that allows them to get the freedom in the end. But so Ken Casey. So I suppose autonomy, freedom, striving to be better, kind of thing.
It just sounds like a great read.
And it's short as well, but I really liked it.
You recommend it? Okay, One Flew Over the Cuckoo's Nest by Kevin Casey. Thank you. 3 great picks.
Yeah, a lot of thought going into those. Thank you, Laurence.
No problem.
Our micro discussion next, and I'm not sure if this is a first or not, because it's a second paper involving our guest, Poisoning in Adolescents in the UK, a review of inquiries to the National Poisons Information Service, 2025 Archives of Disease in Childhood. Lawrence's colleagues, Annie Watt and colleagues, with Laurence listed. What did you tell us what you did then, Laurence, with this particular paper?
So what we wanted to look at was at adolescents, so really between the age of about 10 to 19, and to look at what was happening with poisoning in this particular age group. So not looking at the younger children, but seeing in this particular interesting demographic what was happening in terms of inquiries to the National Poisons Information Service. So what we did was that there was I must say that Annie Watt, based in Edinburgh, did most of the work on this. Very important to say.
Very good.
We looked at inquiries from 2015 to 2022 to the NPIS, and I think there were total almost 30,000 inquiries related to adolescent poisoning. And what we saw is that about half of those, or 50%, were intentional poisoning. So that is with the idea about kind of self-harm. That said, in terms of fatalities, the numbers are relatively low. There were about 44 fatalities. So a very low percentage from the total number of inquiries, which I suppose is
0.1, I think, wasn't it? 0.1%, I think.
Yeah. And of those intentional poisonings, pharmaceutical poisoning was the most common, and that was paracetamol, which I've already talked about. So a very common poisoning, and that made up about 50 to 60%. I think.
Laurence, can I just ask about that? Sorry, because we're talking about children. Is some of that around, the restriction on the number of tablets that you can have and that you can buy, in that 32, isn't it? Is it 16 or 32 if you get the pharmacist agreement? But for a big adult, that's probably not going to be enough to be serious, is it? But is it the case that because you're talking about much smaller people, although I know milligram per kilo in children technically, but is there a thing there that the actual restriction quantity doesn't work for children as much, or am I barking up the wrong tree?
So you're quite right. So if you had a child who's 40 kilograms in weight, and 16 tablets is 8 grams of paracetamol, then that would be 200 milligrams per kilogram. So potentially could still be a toxic dose certainly of paracetamol, 200 milligrams per kilogram. And that's a dose which could produce hepatotoxicity. So I think that's something important to say.
I think what your paper was suggesting, wasn't it, was that well, there's a couple of things that stood out for me, but in reference to that point, it was people were tending to use what was readily available, wasn't it? So it's paracetamol, propranolol, interestingly. So it's either been prescribed for them or their parents. And NSAIDs was the other one, wasn't it? Was
non-steroidals.
The third one, so presumably ibuprofen or aspirin. So it was more. It wasn't the choice of drugs, it's more that these were drugs of convenience, wasn't it?
It is, and I think also, I guess a more modern aspect of that is that, of course, those restrictions are only in one place, one shop. So if someone wishes to subvert those restrictions, it's not necessarily that difficult. But yeah, I think, as you said, it's about convenience. One of the drugs that does feature in the fatalities in that paper, and though only two, but quite a rarely used drug, is colchicine, and this is another drug that very much concerns us in toxicology. It's a very toxic medication, and that's something that we also a drug that we worry about, and we've done some work on that as well. And similarly, maybe to propranolol, there's not always an appreciation of colchicine and the problems that it can cause as well.
I'm glad you said that, Lawrence. So if I go back to my early morning post-take ward rounds, I can still distinctly remember a young man who was in a difficult, he was stuck in a mental health sense. He found his grandmother's colchicine. She was taking it for gout. They have it sat around in the house because, as you know, they take it as and when if they get a gout attack. He doesn't know what it is from anything. He takes it with a load of other stuff. And to this day, I've always said to anybody that prescribes it, do you know how dirty this drug is? Do you know how dirty this drug is? Because this guy, literally, he got every single condition that's listed due to the amount. He took a lot, okay? But I remember he was still on the ward a week later. He'd had kidney failure, liver failure. He got respiratory toxicity. Neurological toxicity. Is properly filthy stuff, isn't it?
It is. And we don't, I'm always a bit reticent, and maybe when we edited this, about maybe being too...
That's okay, I can do that bit.
It's a danger. We're always quite nervous about saying how deadly or something is, in case it encourages.
Well, that goes on to my next point. Was there's a couple of conclusions in the paper, and one of them, there's obviously a point we've already referenced in relation to propranolol, but it's about, obviously, there's a trend reflected in the paper, isn't there, particularly post-COVID, and that's worrying that adolescents might be, for want of a better word, self-harming more. And so the attempts that you're seeing are reflecting a broader societal trend around adolescent mental health. So that's one issue. But I think one of your suggestions was about education on the toxicity of some of these things. And you've just sort of answered my question, really, because I worry about that, because I think that's not really the issue. I think education possibly is an issue, but the issue is, why are young people suffering from more mental health? And I'm not sure that education about toxicity would really have much of an effect in or could even make it worse. But it's a difficult question.
I think this is a really difficult question to answer and know. And I think
that's the pleasure of coming on the Oral Apothecary podcast.
I would say that the education of healthcare professionals is really important, particularly prescribers, to know the risks of these medications, whether it's colchicine, propranolol, or something else. I think the difficulty is if you do go to people, particularly who are in a difficult place, and say, this particular substance is very dangerous to you, there is a chance that you may be in fact promoting that.
That was my point, yeah.
You have to educate the healthcare professionals what to look out for and how to manage it. And so I think it's getting that balance.
Let me ask you a slightly easier question then, but on the same vein, because when we discussed this previously, this similar topic, we looked at the national database for all people, and it included not just prescription drugs, but the sorts of things that people take, particularly children, which doesn't go into in great detail in this particular study. I'm sure you found them and you'll be able to tell us. But I remember distinctly, because I remember having to explain to Gimmo what some of it was. But the oil that people put in, is it reed oil? You know how I was explaining, your wife's probably put these out, like the oil that you then put the sticks in, and those sorts of things, and the capsules like the Persil and and one of the points that we made, and we said at the time, we need to get a toxicologist on to answer this, so this is our opportunity, is from a harm reduction strategy or a public health intervention, how do we do better on that? So that's not, I take your point about we worry about giving the information to people who might then use it. But for people like Persil, let's take them as an example, could be somebody else. Do you guys have any clout in relation to getting them to understand you've got to make your product less likely to be taken accidentally by a child?
Yeah, and I think the kind of so-called liquid tabs is probably a case in point where it really, I suppose, about 10 to 15 years ago started to become a significant problem for a whole host of reasons, mainly being that the attractiveness of the packaging, they're very bright, they almost look like sweets, and they were quite toxic. So a couple of papers, a recognition of this as a growing problem and calls coming into the Poisons Information Service and largely children coming to harm, resulted in conversations with the manufacturers and establishment of a code. So you'll notice that all the packaging is now opaque. They don't no longer come in clear boxes. They tend to be kind of well sealed, and there's also clear marking on them to keep out of reach of children and so forth. So there has been some progress.
That's good. That's good to hear. And as I say, with a safety hat on and Gimmo with his improvement, that's what you want, isn't it? Well, first of all, you don't have it available. Secondly, is how do you lock and key, or square peg round hole. So yeah, making it opaque, I get that. I remember there was a thing about where you had to click the lid down, a bit like getting through a baby gate. You have to be of a certain age to be able to work out what it is that you need to do to be able to open the box. So it's really good to hear that actually that kind of stuff does go on, because when you look at the numbers and you like with this paper, you still think to yourself, where have we moved on? Right? And the answer is sometimes you struggle to know whether how we've moved on or not.
Yeah, and I think as we come up with these new products, then we start to find new issues. Something that's been quite interesting there, Arvind Varaya up in Edinburgh, there's been a lot of work on glycerol and slushies. I don't know if you came across this. So essentially young children,
I've seen this, yeah.
If they drink lots of these slushies that contain glycerol, they can end up having a kind of hypoglycemic acidosis. So there's now been recommendations that young children should only have kind of one slushy drink, because they've actually been admitted to hospital with profound acidosis and hypoglycemia from glycerol.
Okay.
So
I've not heard that. Okay.
Yeah, so there is these. We're in the Poison Service. We do act sometimes as a little bit of maybe a barometer or to identify if there's these issues going on.
Yeah. Oh, that's good to know. Jamie, you've been very quiet tonight. What do you think about this paper?
Oh, I was going to say the paper's past, really, isn't it? But I mean, the bit I was going to ask Laurence was the paper is only about calls to the Poisons Information Centres, isn't it? And a lot of centres will manage many of these things. So this is not tip of the iceberg, but actually it's what's your gut feel for centres that know they see these things routinely coming through the door, they know how to manage them, and they're not making the call. What does that look like?
Yeah, and I think that's where TalkSpace comes in. So we can look at TalkSpace accesses, and we can get an idea of how many times that's consulted on certain pages, and that gives an idea. But even then, the Many places will have their own protocols, which may or may not be based on NPIS and tox-based advice, which we'll never know about. So I think you're probably quite right to look at telephone inquiries potentially as a tip of iceberg, but I think it depends on what it is, because if we go back to something like colchicine, if you're to look at those inquiries, we probably get a higher proportion of them would call in because they're much more severely unwell. Whereas if you take something like paracetamol, which is thousands and thousands of presentations every year to A&E, we'll still the most common call we get, but it's a much lower proportion of the number who have attended hospital.
And it would be fairly routine for an A&E to deal with that,
100%,
so they wouldn't need to report it, would they?
Yeah.
And then the other thing I'll point out, to be remiss of me, I met my wife over a toxicology case, Laurence. I don't know if you're aware of that.
Oh, right.
That my desert island drug is oil of wintergreen.
Horrible stuff. Yeah.
Well, and so the story was that a young child came off the rugby pitch and the wintergreen was stored in a pop bottle, and he necked a couple of gulps of oil of wintergreen and ended up with severe salicylate poisoning.
Yeah.
But for another time. Then the other thing I wanted to say, listening to you, Laurence, when you were describing your working week, and I've worked closely with poisons information professionals for most of my career and clinical pharmacologists, and it's just incredible. And describing the work of the Poison Information Service and your colleagues, not everybody knows about you or what the work of the centres, and you're prolific in publishing on a UK basis. I know that. It's just impressive and fascinating, I think, is worthy of saying. So, very, very impressed. I know when I spoke to your colleagues a couple of weeks ago, they caught between the tension, and we'll have this on this podcast, actually, because it's not only healthcare professionals that listen to the podcast. So the Poisons Information Service is for healthcare professionals, isn't it? It's not for members of the public to contact you. And that's that sort of tension of advertising on one hand and talking about the service and what you do, but it's not for members of the public, is it?
For anything else, ask Frank.
We're not members of public service, I think, which in Ireland they've got that, in the States, of course. But I suppose to some extent NHS 111 acts as a gateway for healthcare advice. And they do a significant proportion of our inquiries are due to a kind of handed on. Though we never deal directly with members of the public, those public inquiries come to NHS 111 and then do come on to us. So we kind of by a roundabout way we do interact.
Okay, thank you. A big thank you to Laurence for joining us on the Oral Apothecary, for sharing his stories, his desert island drug, his career anthem, and his book for the Oral Apothecary Library. Coming up next time, we'll be joined by Brian McKenna. Brian is Director of Research and NHS Service Analytics at the Bennett Institute at the University of Oxford. Join us next time on the Oral Apothecary. You can contact us via X at Oral Apothecary, just about. You can follow us on LinkedIn. I think that's where we'd really like to engage with you. Gimmo now with the final ingredient.
Yeah, so thank you very much, Laurence. That was fab. And one thing we didn't mention today, we probably should, is people can still also check out your TED Talk, Jamie. I think we referenced it last time that it was coming out. It is out, and it's all over our social media, and we'll keep it permanently in the show notes. So check it out. It's fantastic. So today's final ingredient: discovery is seeing what everybody else has seen and thinking what nobody else has thought. So who said that? So it was Sir James Black, so a compatriot of yours, Laurence. So in the 1950s, a young Scottish doctor named James Black was working at a teaching hospital when he noticed something strange in patients with angina. So as the chest pain caused by poor blood flow to the heart would often get worse under stress. And so this was the heart responding to adrenaline. So it's an example of the body's own biology pushing them towards crisis. Where others saw symptoms, Black saw a system, and more importantly, a target. And so at the time, in the 1950s, drug discovery was mostly a game of trial and error. So you tested hundreds of chemicals and lots of things and just hoped one of them worked. But Black had a different idea. He said, what if we specifically design a drug to block adrenaline and calm the heart directly. And so that began the birth of rational drug design. And so the idea that you can understand how a disease works at a molecular level, you can build a medicine specifically to fit the problem, like a key in a lock. And so after hundreds of experiments in 1964, what drug did he discover?
Propranolol.
Yeah, so today's drug was propranolol, so the world's first beta blocker. And so we all know about propranolol. Didn't just help angina, it changed the game for high blood pressure, anxiety, arrhythmia, and as we know, became a secret weapon of concert pianists and snooker players and public speakers who want to steady the nerves. But I suppose my point today was propranolol was more than just a new drug. It was the first time it was proof that you could design medicines on purpose and not by accident. And so introduced that whole new era that we're still reaping the benefits of today. And to James Black, you mentioned this, Steve, last week. What else did he go on to develop?
Cimetidine.
And it's also come up today. So the first blockbuster ulcer drug, and in 1988 he won the Nobel Peace Prize.
Not just thrown together.
Yeah, the Nobel Prize for his trouble. So just to repeat the phrase at the beginning, discovery is seeing what everyone else has seen and thinking what nobody else has thought.
You have been listening to a 3 Apothecaries production. Sound engineer Jimbo Slough, original music Jamie Brewster, artwork by David Baker and Jacob Howard.
Thanks for listening to the Oral Apothecary podcast, where we always dispense with accuracy.
This episode of The Oral Apothecary is sponsored by OneLessPill.com, a medicines optimization consultancy.